Welcome to the DocTalks Podcast. I'm your host, Mandi Fields. I'm here to ask medical experts the questions you might have about diseases and conditions, from heart health to dementia and everything in between. Join me for a conversation where we get right to the points you need to know to navigate Canadian medicine and hospital healthcare. Hi, I'm Mandi Fields. Welcome to the DocTalks Podcast, brought to you by St. Joseph's Healthcare London. Do you have a favorite smell? Mine is spring. How would you feel if you could no longer smell your favorite scent? Changes in your ability to smell can happen after common illnesses such as the cold, flu, and COVID-19, and uncommon ones like brain injury, and sometimes can even lead to the loss of smell, known as anosmia. Today, I'm talking to Dr. Leigh Sowerby, Division Head of Rhinology and Skull-Base Surgery at St. Joseph's and Associate Professor in the Department of Otolaryngology, Head and Neck Surgery at Western University. Dr. Sowerby is also a scientist with Lawson Research Institute. Dr. Sowerby is an expert in nasal obstructions and reconstruction, sinusitis, and sinonasal disorders. Thank you for joining me today, Dr. Sowerby.
Thanks for having me, Mandi.
I want to share a little bit about your background, though, too, so our listeners out there can have a sense of your knowledge and if they have any questions of who to reach out to. So Dr. Leigh Sowerby is a surgeon with the Otolaryngology Head and Neck Program at St. Joseph's Healthcare London and scientist with Lawson Research Institute. Sowerby graduated from medical school at the University of Calgary in 2006 and from residency at the University of Western Ontario in 2011. He completed further subspecialty training in rhinology and anterior skull-base surgery at the University of Alberta and was subsequently recruited back to London to help treat the large volume of rhinosinusitis patients. Dr. Sowerby's area of interest and expertise is in nasal obstruction and nasal reconstruction, sleep apnea surgery, and anterior skull-base surgery. So let's get to it. Let's get to the first word that I had to look up and have it phonetically spelt for me so I don't mess it up. So what is anosmia?
Thanks for having me. It's an interesting place when we take a step back and look at our senses. We really take our sense for vision, our sense for hearing, but particularly our sense for smell for granted. Vision and hearing is one of those things as kids that you can simulate what it's like to not have that sense. We've all did that, where you close your eyes and see how far down the hall you can walk before you run into a wall. Or we've put headphones on or earplugs. We're trying to protect our ears, but it just gives you a bit of an idea of what it might be like to not have that sense. The sense of smell is different in that it's very hard to simulate what it would be like without that sense. And that, when it is lost, is what we call anosmia.
What drew you to this specialty?
Well, I was kind of drawn into it by accident in that, I went into otolaryngology head and neck surgery because I loved reconstruction in the head and neck area. And generally, for those of us who are working in academics, we do end up subspecializing. And I chose to subspecialize in rhinology and skull-base surgery, which is basically surgery in the area and around the nose. I do also do some facial plastic surgery as well. And it all kind of dovetails nicely with that triangle in the middle of your face. Smell is also an integral part of rhinology. But historically, it's been something that's really not well appreciated. It's not well investigated and, frankly, not well treated when that sense is lost. COVID-19 has changed that to some degree in that there's been a renewed area of interest and focus on trying to address those patients who lose their sense of smell or have a distortion in their sense of smell. The one thing I think is really interesting with smell, we jokingly refer to it as like the Rodney Dangerfield of senses. And the older of our listening audience will appreciate the joke. But it's just not appreciated. It doesn't get any respect. And part of it is that it's hard to simulate what it's like to lose that sense, like I was alluding to earlier. And there was a really nice study. It was, I think, the University of Vermont did it. And they actually went onto a campus and they asked, it was like a willingness to trade. How much would it cost or would you be willing to give up for, losing your sense of smell? And it was almost laughable. There was like 20% of respondents were like, they would give up their sense of smell for a new iPhone.
Oh, wow.
It just shows you that we just don't appreciate that sense until it's not there. And like I said, we spend a lot of our life we're passively smelling what we go through our day to day. It's only when you have something really strong that kind of wafts in your direction, like, whoa, oh, wow, that's like bad BO, or that's, wow, like who brought the flowers in, right? Like there's something strong that triggers in our environment. And it also, that value that's placed on smell, I think is, again, it's underappreciated. So we're seeing that change a little bit with the number of people who lost their sense of smell temporarily with COVID and then had it return. Because they've gone through it, there's now this empathy for patients who've lost their sense of smell. You can see it in things like, common carrier insurance, right? So if you get in an accident, you've got your car insurance. Your car insurance actually has an established value for if you lose one eye, or if you lose sight in both eyes, or if you lose hearing in one ear, or you lose hearing in both ears. You lose a finger, there's a different value for your index finger than there is for your pinky finger. There is no mention of any value for the loss of smell.
Wow.
And it makes you,
I never thought about it.
It makes you ask the question why, right? Like why is it a value? It's like, certainly you can live without it, but for some of our patients, it's not a life that they are particularly enjoying. The other challenges I think we've run into in this, because it's a relatively undervalued sense, the research dollars aren't there. Then we don't have the evaluative abilities that we have for the other senses. When I kind of always chuckle to myself when I think, one floor below me at St. Joseph's Hospital, we have an unbelievable department of ophthalmology that's dedicated to that one sense of vision. And they do an amazing job of assessing it. Their objective assessments, they have ways of imaging the back of the eye. They can image the visual fields that people can see. They can take these beautiful high resolution pictures of the optic disc and the retina, and from all of that, make a diagnosis and a treatment plan for patients. And we have nothing like that for smell.
And why do you think that? Is it a quality of life versus a decision that it's not a health crisis?
I think so. Yeah, I think it's undervalued. It's a sense that, when you haven't lost it yourself, it's quite easy to say, you can just live without your sense of smell, no big deal, until you're living that life. And when the patients who are living that life were in the minority, very small minority, I think it's a lot harder to advocate for the research dollars, for the testing, for the evaluation. And I think also it comes back to really what we're able to do with it, right? For vision, you can have corrective lenses. And so because there's corrective lenses available, we have optometrists, and we have places like there's dozens of them in London where you can go and you can buy glasses. And it's the same for hearing. You can go and get hearing aids without a referral to a doctor. You can just walk in, get a hearing test, and that hearing aid company will be more than happy to set you up with hearing aids that are going to help you with amplifying that sense. We have nothing similar like that for smell. And I think because of that, it just hasn't kind of evolved in the same direction as of yet.
And what would the numbers be? Like, how many patients would be coming forward saying, I have a loss of smell?
It's interesting whenever you take a step back and you're looking at, incidence and prevalence, it's really hard to get a good feel for those numbers because there's this perception that nothing can be done or that there's no tests to evaluate it or otherwise. There's a lot of patients out there that just live with it, right? They don't mention it to their family doctor. So it's not documented. They don't have it on their chart. But, when you think about the aids that we have and the accessibility and stuff, we have ways of marking that down on someone's chart. Right? Okay, this person's visually impaired. And so, in the OR, we have a little acronym if they're hearing impaired or they're vision impaired. That makes sense because it factors into the communication, right? So that person can come in, they can have surgery with a loss of smell, and it's not going to affect their patient journey, right? So it's, in that sense, it doesn't have the same value placed on it as our other senses.
So how can you tell if a patient's loss of smell is temporary or permanent?
That's a great question. So to answer that question, it really comes back to why the loss of smell has happened for a patient. And there's a number of different reasons why that can happen. We can see it from trauma. So any patient who has significant head trauma that ends up in the ICU, the little fibers that descend from the brain into the nose or smell often get sheared off in that area. And for those patients, that will be a permanent loss of smell. They can have some recovery, but they tend to be the patients who are least likely to have a complete recovery. You can have a loss of smell from obstruction. So if when we're breathing, the odorants that are in the air can't get to the area where smell is in the nose, you're not going to be able to smell what's in the environment. Some of the more common reasons for that could be a deviation or a bend in the septum. That's the middle part of the nose. Or it can be related to polyps that are growing in the sinuses. And so if somebody has chronic rhinosinusitis with polyposis, if there's an obstruction of airflow up into the area where smell is, they're not going to be able to smell. One of the things that I think is missed is we'll often see people who say, oh, I can't taste. Taste is off. Really what they mean is flavor. So when we think of taste in its purest form, taste is just sweet, sour, salty, bitter. And then this fifth aspect called umami, which is like the protein flavors. So if you ever have like a nice juicy steak and you're like, oh, this is so good, that's umami. It's also what gets stimulated with MSG. And so in its purest form, those are the 5 elements of taste. What we think of when we think of why a strawberry tastes like a strawberry is actually flavor. And that flavor is derived from retronasal olfaction. So as you're chewing, the odorants come out from the food and they go up actually behind your palate. And you end up smelling the food while you're eating.
Is that why like McDonald's? Like I'm like, I can taste it before I'm eating it. Is that the same thing?
Exactly. And so, coming back to you asking about the reasons, temporary, permanent. So, somebody who has polyps, they're going to have issues until the polyps are dealt with. Now, sometimes that can be just with medication. Sometimes they need surgery to address that. We do sometimes see it related to neurogenic conditions. So there's an association both with Alzheimer's and Parkinson's with the loss of smell, with the loss of smell actually preceding those conditions by anywhere from 3 to 5 years. The last one, and what we're seeing a lot more lately, is a post-viral anosmia. Now, we saw that before COVID, but in the early days with COVID, up to 50% of patients were losing their smell immediately when they had COVID. 5% of those that lost their smell still had a persistent anosmia 2 months after their bout with COVID. It was quite interesting. We obviously don't have the same sort of access here as there is elsewhere in the world, but some of our colleagues in the United Kingdom, they were some of the first to identify that olfaction or the loss of olfaction was very strongly associated with COVID, because they were seeing a number of these patients who just had this idiopathic anosmia, or this sudden loss of smell. No idea how or why that happened until they started looking into it. And unfortunately, a number of our colleagues in the United Kingdom who are otolaryngologists were actually afflicted with COVID in the very early stages from those patient exposures.
Wow, so they would have had lived experience as both having a specialty in it, but living it.
Exactly.
Okay, so can you taste food and drink without having a sense of smell? Can you taste it?
Another great question. So you can, in that you will have the sweet, the sour, the salty, the bitter, and then that nuance of umami when you're eating or drinking. But a lot of the enjoyment from food is from the flavor of food, and that is the smell. And so for some of our patients, it can be a really big deal. And we encourage them to focus on other things like, the presentation of the food to try and help enhance it. A lot of our patients who've lost smell, they end up using a lot of spice to try and help to enhance that. So they'll use hot sauce to create a different sort of stimulus from eating than what you're getting when you're actually having the nuances of flavor. I have some patients who aren't really bothered by it, and there are other patients who, it's absolutely devastating. We see all sorts come through here, and we have some patients who are sommeliers or chefs that have lost their sense of smell. And, for them, it's not just an enjoyment thing, but it's actually their livelihood that's dependent on the sense of olfaction.
So what would the process be like if I all of a sudden I was noticing I no longer had a sense of smell, and then would I go to my GP and then I would be referred to you, and then how would you diagnose this?
I'm really glad you asked that question. So that's something that we're looking to try and change. In that historically, when you would see your family doctor for the loss of smell, they may remember their lecture from medical school. They may not. They might take a look in your nose. They might not. They might start you on a nasal steroid spray. Like I said, from the history, you can often tell at least some of the nuances and how or why this may have been occurring, and the first steps in how to look at addressing it. But the objective testing is very hard to access. And it would be the same, even for a lot of our colleagues in the community, and through no fault of their own, there is very little standardization in terms of our objective testing of somebody's sense of smell. And so really up until a few years ago, even when you came to see me as a rhinologist, we did not have the tools available for us to be able to objectively measure somebody's sense of smell. To put that in context, that would be like you going to see the ophthalmologists or to see our otologists. Or you walk into a place that sells hearing aids and say, I can't hear. And they'd be like, okay, here are your hearing aids, but we're not going to test your sense of hearing. It just doesn't happen. And the same with vision, right? You would never go and see somebody and not have them do just the basic Snellen chart. Can you read the letters? And we don't have the same sort of thing with smell. We're trying to change that at St. Joe's now. And so We're looking to kind of expand what we're able to offer in terms of evaluating olfaction for those who are interested in having that done, because that objective testing can help. I've seen it both ways. We've seen patients who, just as part of our workup for their polyps in their nose, we test them and they can't smell at all, and they're not really bothered by it, because I've had patients who are farmers who say, well, I don't smell the manure when I'm spreading it on the field now, so that's a good thing. And then we've seen the opposite, where we've had other patients come and see us from far away because they're devastated by their loss of smell. And then when we objectively test their smell, they're actually testing within the population norms. Now, that's not to say that that's normal for that person. That person was likely a super smeller before they had lost their sense of smell. But it's very helpful for us to be able to quantify where they're currently performing in terms of deciding what the next step should be for helping rehabilitate that person.
So you just said super smeller. When I received your bio and I was reading up on it, it brought me to a time when my son, I think, was a super smeller when he was younger. He was always sniffing. And when he got to be about 10 or 11, I'm like, think you got to stop sniffing your friends. So what makes somebody a super smeller? Where does that come from?
I think there's a clear genetic component to that. Some people are just gifted with it. It's the same as some people we talked about them having eagle eyes, and being able to see further away. A lot of that is just physiologically how you're built. But there is an element of practice. And we do see that in, sommelier programs, in the perfumery programs, that sort of thing. By the end of a program, people are actually able to enhance their sense of smell by practicing. That's a key cornerstone of our rehabilitation with patients who've lost their sense of smell, is that olfactory training. So basically relearning what smells are. The olfactory cleft, where the neuroepithelium is relatively unique for sensory organs in that it has the ability to regenerate. So that's different than your retina. You get one retina, the retina goes, you don't get it back. The same with the hearing hairs in the ear. When those hairs are gone, they don't come back. And so that's, again, comes back to the importance for our kids when they're young of making sure that they're not listening to music too loud when they're listening to, their AirPods or otherwise, because, once that hearing is gone, it doesn't come back. So the neuroepithelium in the nose is unique in that it actually can regenerate. And there's been now a number of studies that have shown that olfactory training helps in that neuroregeneration and recovery after an insult that's caused the loss. Coming back to the question of, what can you do or what makes somebody a super smeller? So there is that element, but there's also an element of deprivation. And so there's some evidence also showing that when you're more dependent on a sense, the ability with that sense improves. And so what I mean by that is if you lose your ability to see, you're going to be more reliant on your nose than you otherwise would be. When you think about smell, it's very different than our other senses. You can see somebody who you haven't seen in 10 years, like a close friend you haven't seen in 10 years. You'll recognize that person. You can't say the same for smell. And part of it is we go through life passively smelling. We don't spend a lot of time actively thinking about smelling when we're, in our day-to-day activities. And that comes back to really why or how that training and that active practice can help with improving the cognitive processing of the signal that the brain's getting. When you look at the ability for dogs, one of my favorite YouTube shows to watch when I have time to watch TV is Mark Rober. And he does some really entertaining, fun things. And they did one on smell. And on that episode, they showed just the power of smell for dogs. So they had a room where they had 20 people in the room. They all touched a piece of cloth, and one of the 20 of those people left. And they brought the dog into the room, and the dog was able to smell that cloth and discern by going around the room which of the 20 it was that had left the room, and they could follow that scent trail. And what's been shown, this is again, the torture that happens to graduate students, is there was a really neat study done where they laid a scent trail and they put earmuffs on and blindfolded graduate students. And they showed that when you were solely dependent on your sense of smell, not only were the students able to find the trail, but they were able to follow the trail. So they were able to follow the trail from the weakest point to the strongest point. Again, just speaking to the power of that sense when we use it.
Okay, I know listeners can't see your face right now, but you look so happy. Do you love what you do? Because your eyes are lit up.
I like problems. And, to me, this is an area where I see a lot of opportunity. It's frustrating because there's not a lot that we can offer, but it's also an area where I see a lot of opportunity for growth and for us to be able to improve what we're currently able to offer.
Okay, let's go over to research then. So what treatment options are available and how would a patient become part of your research studies?
So it all depends on the reason why they've lost their sense of smell. Currently, we have a few different studies. One we've finished that was actually looking at taking people who smelled normally and seeing if we could enhance it with olfactory training. We have another study where we're looking currently at patients who lost their sense of smell from COVID, but when they've had it come back, they've developed parosmia. And so parosmias are where the smell is distorted or things smell like something they're not supposed to. For those patients, the most common things they are struggling with are onions, garlic, meat. And we've had some patients say that, they can't stand the smell of their partner anymore. So you can imagine how devastating that would be if, all of a sudden you are repulsed by the smell of the person that you have committed to spending the rest of your life with. And so right now with my colleagues in the pain clinic with Jeff Bellingham and Noel Masrati, we're doing an investigation. We're looking at doing an injection in the neck and seeing if that actually helps with the parosmia. There's lots of anecdotal reports, and this one is it's a double-blinded randomized controlled trial. Half of the group are going to get saline or salt water in the neck. The other half are getting anesthetic, and we're going to see if that works. And so that one we're really excited about. We have a few other studies that we're looking to get off the ground in terms of taking those patients who have anosmia or loss of smell. One is with the head trauma patients. So we're looking to see if we can identify those patients earlier. So you can imagine if you've been in a devastating car accident or otherwise where you've been in the ICU and then you're at Parkwood for rehabilitation, the primary focus is on getting you talking, right? And getting you walking and, the activities of daily living, and smell kind of takes a bit of a backseat. And there's some evidence that if we're able to identify those patients earlier, that if we're able to intervene, that we can perhaps enhance their recovery. And so we're working on developing a bedside smell tester that can hopefully identify and screen those patients early so that we can see them and intervene to try and help with their recovery.
And would that be different smells, like the bedside smell tester?
Exactly. So just an easy little kind of like, you can almost think of like the smelling markers we've all used as kids when you had the different ones, sort of along those lines. So something easy where we can screen patients. And, coming back to COVID, it was interesting how it took COVID to spread to Europe to identify that olfaction was profoundly affected. Our patients in China who were affected with COVID, at the very, very early stages, they also had olfactory loss. And that was reported retrospectively, but it wasn't reported as a cardinal symptom at the very beginning. And I think it speaks to the importance or the weight that's placed on that. And so, if you think of our stereotypical Europeans, right? They love their food, they love their wine, they're into the finer things in life. And, smell is an important part of this. And so, it makes sense that was a big part of what was reported with the symptoms they were having. And we're trying to kind of bring that focus back to it. So, when our patients are in a situation like at Parkwood where they're recovering, that is assessed and that will allow us to hopefully enhance their recovery. We're also hoping to be able to offer olfactory testing for those who want it, so, working with our colleagues in neurology and maybe looking at developing some screening tools along those lines for those who are at risk for Alzheimer's or Parkinson's, and seeing if we can pick those up early based on their loss of smell before the other symptoms start. So before the tremor or the memory loss or otherwise, and seeing if we can screen patients earlier that way.
Who made the decision on what the smells would be on the smell test or the super sniffer?
I love the name. We actually haven't named it yet. So when we were looking at what to do, we were thinking about, well, how can we make it easy and portable? And so we've come up with like a little handheld one that has some basically smelling markers attached to it. And we wanted to do some safety ones as well as some smells that were cross-culturally recognizable. And so you can imagine we run into this actually with some of our more formal smell tests. One of the smells that's on our smell test is turpentine. Well, you've never used turpentine. You don't know what turpentine smells like. And we do find, as Canada is very multicultural, we have a number of people who are relatively new immigrants to Canada. And there are smells that they simply might not be familiar with. And so because of that, we chose lemon, vanilla, and cinnamon. They seem to be relatively ubiquitous worldwide. And then from a safety perspective, we went with the rotten egg smell and smoke. So the natural gas is the rotten egg. I'm surprised at the number of people that comment that they think it smells like BO. But really what we're going for is that they are detecting a negative smell. And so you can think of smells as like positive or negative. There's some theories about, different prisms of smell that have been prescribed in the past, like aromatic, woody, floral, acrid, that sort of thing. And so, we tried to have a balance that way with what we're detecting.
Great. In your experience, what are patients most worried about when they are experiencing loss of smell?
That's a great question. So I would say safety is a big one that comes up. I think the biggest concern is that people are worried that they won't be able to smell smoke when there's a fire, or, when they're cooking, they can't tell when, something might be burning in the oven. There's also the concern, of like a natural gas leak and not being able to smell that there's a gas leak in their house. We often rely on the sniff test when we're eating food to, make sure that something's still good. And obviously, if you've lost your sense of smell, you can't rely on the sniff test. You have to be a little more careful about observing the expiration dates on things when they do expire. And so, part of our counseling with patients when they do have a loss of smell is that it is really important for those patients to make sure that they're changing their batteries and their smoke detectors. And we encourage them all to purchase a natural gas detector if they have natural gas in the house.
Oh, that makes a lot of sense. So where would someone go if they notice changes to their sense of smell and taste?
Great question. Again, there are some web resources that are available right now. So there's one called Fifth Sense. It's an organization based out of the UK that gives a little bit of background. It's really nice in terms of its summaries that it has available there. We're working on one that will be more like of a Canadian focus. And so hopefully in the next few months, we'll actually have that website launched to provide more information for patients, and also hopefully to be able to provide smell tests that patients can order and perform themselves and have us evaluate and score them for them. We're also obviously able to assess those patients. So the usual referral pathway for patients to see me for that is via a primary care provider, where a referral is made, and then we see them for their loss of smell. But we're hoping to expedite that, and that if they wish to be assessed without seeing somebody, that they'll be able to do a smell test at home.
Can changes in their smell taste be affected by hormones and perimenopause?
So they can, but far and away the most common place where we see it is actually during pregnancy. And I'm sure many of our listeners who have been pregnant or who have had a partner who was pregnant will reflect back on that time and be like, oh yeah, that is a thing. It's most definitely something that we do see and we hear about. Usually it is self-limited by the pregnancy. We do find some patients have some distortion afterwards, but that would be in the minority. For most, it's just a very heightened sense. And it's thought that there's an evolutionary advantage with that. So you can imagine, okay, you're pregnant, you've got a fetus, you're trying to protect the fetus. You having an enhanced sense of smell allows you to identify danger in an expedited way that allows you to then protect your progeny.
Thank you. So can you share with us like a highlight, like a patient that it was like a really challenging situation and you just dove in and you were able to help them get their sense of smell back? Like, do you have a highlight patient moment?
I would say so. In rhinology, the main condition that we spend a lot of time treating is chronic rhinosinusitis. And so chronic rhinosinusitis with polyposis, there's an obstructive part, but there's also inflammation in the olfactory cleft. And so for our patients who have more severe disease, they often will have a decrease in their sense of smell. We do surgery, we're able to improve a lot of the other stuff that they have happening. But often the sense of smell is persistently decreased afterwards. One of the newer evolutions in our treatment of that condition are medications called biologics. So biologics are monoclonal antibodies. And what that means is they're one specific antibody that's repeated again and again and again and again, and usually just in a cell line. And then those antibodies are collected and then they're made into an injection. And what that's doing is helping to treat the root cause of why that inflammation is happening in the nose and the sinuses. And we're seeing that for those patients, so like the worst of our worst patients who aren't getting their sense of smell back with our traditional treatment methodologies, biologics seem to be making a difference for some of those patients. And for some of them, it's been 20 years or so since they've been able to smell. And they're just so happy when they're finally actually getting some smell back.
That's very cool. One final question. What is your favorite smell?
Oh, that's a good question. I've actually not really ever thought about what my favorite smell would be.
While you're thinking about it, I was thinking about in 1999, I flew to Hawaii and I arrived at night. And so I couldn't see a thing, but all I could smell was the flora. I've never forgotten that. I've never made it back to Hawaii. And it was, so when you're talking about the sense of smell and it just still to this day, it was one of the most powerful things I've ever experienced was that evening waking up or landing in Hawaii because of the smell.
I would say probably if I had to choose a smell, I would say it's probably either that smell right after a rain, like that fresh smell that you get, or the smell of the ocean. We don't see that as much in London, Ontario, but it brings back memories. And that, that's the other thing with smell that's really interesting is it's plugged directly into some of the more primitive parts of the brain. And so a smell can almost instantaneously evoke a memory. And that memory, it may not even be like the discrete memory itself, but it evokes the emotions that are associated with that memory.
Sounds almost poetic. So thank you. Thank you so much for joining us today, Dr. Sowerby. That's it for this episode of the DocTalks Podcast. Thanks for listening, and join us next time when we'll continue our conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. Be sure to subscribe and follow us on Facebook and Twitter at St. Joseph's London, or visit sjhc.london.on.ca/podcast. Until then, stay healthy.